Welcome to the weekly Neurology Deep Dive, produced by Amara Gavanini. Today, we're embarking on a really crucial journey, a deep dive into the latest advancements in intracerebral hemorrhage management. And we're specifically focusing on a pivotal study exploring the promise of minimally invasive surgery.
And just a reminder before we start, this deep dive is crafted purely for educational purposes. We're summarizing complex, cutting-edge research for you, our colleagues in the neurological community. While we'll hit the most critical insights, we really do recommend reading the full papers, for the complete details in that crucial context.
Absolutely. We've meticulously distilled information from quite a comprehensive set of documents for this one. There's a detailed protocol document, its accompanying statistical analysis plan, and also an adaptive design report. And these are all for what's known as the MIND study. That's M-I-N-D. A prospective, multi-center study of Artemis, a minimally invasive neuroevacuation device in the removal of intracerebral hemorrhage. So that material really forms the bedrock for today.
Right. Our mission today is essentially to cut through the sheer volume of information. We want to equip you with the crucial data, the clever trial designs involved, and importantly, what all of this really means for your practice. Think of it as, well, your express lane to being truly well-informed about the cutting edge in this very challenging field.
Okay, before we really wade into the specifics then, what's the absolute must-know takeaway, the practical point for our colleagues listening right from the get-go?
I think the most critical insight is this. The MIND study represents a pivotal moment, and that's because it's rigorously testing a purely mechanical, minimally invasive approach using this Artemis device. It's for supratentorial intracerebral hemorrhage. For decades, our traditional tools, both medical and conventional open surgical interventions they've largely failed to really move the needle on patient outcomes. So if MIND confirms what some of the early data in prior trials suggest, we could be looking at a much safer, more targeted way to achieve significant clot reduction. And this reduction, as we'll discuss, is increasingly recognized as the absolute key to better functional recovery. So this is just about a new device. It's about potentially redefining our standard of care, focusing on what truly matters. Effective, precise clot removal, without those added complexities of, say, adjunct therapies like thrombolytics.
That initial insight really sets a powerful stage. It highlights both, the desperate need for innovation and the potential for a real paradigm shift here. So let's now transition into the narrative of how we started pushing those boundaries and exploring new frontiers. Let's begin with the very first attempts at these less invasive interventions. One, the enduring challenge of intracerebral hemorrhage. Intracerebral hemorrhage, or ICH, it remains just a devastating condition. It accounts for a significant chunk of all strokes. And, despite decades of research, truly effective interventions, medical or surgical, to consistently cut mortality or significantly improve functional outcomes, well, they've largely been elusive. It's a critical area where innovation is just desperately needed. Our current options often feel, frankly, insufficient.
Yes, and what's particularly striking here, maybe even a bit sobering, is that the mortality rate for intracerebral hemorrhage has remained relatively stable for the past several decades, despite all our advancements in neurocritical care. That grim statistic just underscores the urgent need for new, effective strategies. Now, current best medical management, following American Heart Association and European Stroke Organization guidelines, it typically involves immediate intensive care unit admission, or at least placement in a monitored stroke unit for a minimum of 24 hours. This includes, careful airway assessment and management, rigorous blood pressure control, often aiming for systolic below 140 these days, meticulous glucose management, avoiding both hyper and hypoglycemia, and the prompt assessment and correction of any coagulopathies, whether inherent or drug-induced. And of course, in cases with hydrocephalus or high intracranial pressure, maybe from mass effect or associated intraventricular hemorrhage, you might need an emergent ventricular drain. Sometimes with more pronounced mass effect or herniation signs, even a craniectomy or craniotomy for decompression or evacuation might be necessary.
Right. So given that foundational medical management, what about more aggressive medical strategies? Have we seen any breakthroughs there that have genuinely shifted the paradigm for patient outcomes?
Unfortunately, no. That's been a source of frustration. Despite numerous attempts, multiple randomized controlled trials looking at aggressive medical management have consistently failed to show improved clinical outcomes or survival. This includes trials specifically targeting cerebral edema with agents like mannitol or hypertonic saline, and also those exploring things like recombinant factor VIA. Remember the FAST trial?
Vaguely, yes.
A significant study, over 800 patients with acute intracerebral hemorrhage. They randomized them to placebo or recombinant factor within 4 hours. Despite the rationale, the trial showed no significant benefit. In fact, there were some concerns about thrombotic complications. And similarly, trials focusing on aggressive management of cerebral edema, they also failed to show significant improvement in function or survival. So these findings really solidified the understanding that medical management, while absolutely crucial for supportive care, hasn't provided that definitive solution to the core problem of the clot itself.
That is truly sobering. So if aggressive medical management didn't pan out, what about the most direct approach? Traditional open surgery to just remove the clot. For many years, that was the go-to for certain cases. But did the evidence ultimately support its routine use, or did we hit similar roadblocks in the operating room?
That's a critical question, and regrettably, similar challenges persisted with conventional open surgery. We had large randomized controlled trials, most notably the surgical trial in intracerebral hemorrhage the first, or SDH1, and its successor SDH2, and both of these large trials demonstrated no consistent beneficial effect from conventional open surgical hematoma evacuation. In STEACH-H, they compared early surgery to standard medical management. There's a big cohort, over 1,000 patients with supratentorial intracerebral hemorrhage. The results were quite disheartening. About 75% of subjects in both arms had poor clinical outcomes or died. Now, a subgroup analysis of STEACH-HI did suggest a potential benefit, but, and this is key, it was limited only to those subjects with superficial intracerebral hemorrhage, generally defined as within 1 centimeter of the cortex, and crucially, without any associated intraventricular extension. That specific group seemed to do marginally better. So, building on that observation, the STEACH-3 trial was specifically designed to look at this select group patients with superficial hemorrhages.
STEACH randomized about 600 patients to either early surgery or conservative medical management. And again, the outcomes weren't dramatically different. About 59% in the surgical group and about 61% in the medical management group had unfavorable outcomes. There was a trend toward improved mortality at 6 months, about 18% mortality in the early surgery group versus about 24% in the medical group. But this difference did not reach statistical significance. So even when targeting the supposedly best candidates for open surgery, we couldn't prove a clear, broad benefit.
Wow, so even with all that effort in SDH2, specifically targeting those superficial clots, still no statistically significant benefit. That's really disheartening news for this patient population. It became abundantly clear that neither aggressive medical management nor traditional open surgery was the silver bullet. That left us in a frustrating position. What then sparked the ingenuity? What was the compelling force that finally nudged the community towards exploring genuinely new avenues, particularly these less invasive strategies?
2. The evolution of minimally invasive surgery, MIS, for intracerebral hemorrhage.
That's exactly right. The persistent high mortality, the poor functional outcomes. It created this undeniable imperative to rethink everything. If brute force, open craniotomy wasn't consistently working, maybe precision was the answer. This inherent challenge drove us to explore minimally invasive strategies approaches designed to reduce that devastating hemorrhage volume, but with minimal collateral damage to the surrounding healthy brain. And thankfully, these innovative paths have indeed started to show a much more encouraging preliminary signal. So, with conventional methods largely falling short, where did the ingenuity finally kick in? What were some of those early foundational attempts at minimally invasive approaches that started to chip away at this seemingly intractable problem?
That's where the story gets really interesting. The failures really ignited a global push for innovation. Broadly, we saw 2 main avenues emerge, purely mechanical techniques, and then those that integrated thrombolytics to help dissolve the clot. Some of the earliest and perhaps most impactful data came from places like China, specifically the work of Wang and colleagues. They pioneered what they called minimally invasive craniopuncture therapy. It was a relatively straightforward computed tomography-guided aspiration system. What made it so compelling, beyond its elegant simplicity, was the scale. A randomized trial with 465 patients. This study focused on patients with moderate volume intracerebral hemorrhage, generally between 25 and 40 cubic centimeters. The procedure involved computed tomography-guided placement of a puncture needle directly into the hematoma. After aspirating the liquid hematoma, they'd inject a lysis fluid, often urokinase, into the remaining clot. Then a drainage needle was secured and left to drain for 3 to 5 days. And the results, they were quite dramatic. They reported a significant improvement in clinical outcomes. At 90 days, about 41% of the craniopuncture group were dependent, defined as a modified Rankin scale score greater than 2, compared to about 63% in the medical management group. A significant improvement. And this wasn't just a research paper. This specific technique became widely adopted in China, reportedly performed over 150,000 times annually. That really underscores its real-world impact and feasibility.
That number, 150,000 procedures, that's frankly astonishing. It implies a significant level of confidence and success over there. What do you think made that particular purely mechanical approach resonate so strongly? And what key lessons did that phase of innovation teach us before we even started thinking about adding chemical agents?
Well, the sheer volume speaks volumes, doesn't it? It points to perceived efficacy and probably accessibility. What resonated was likely its relative simplicity, the ability to achieve significant clot reduction with a less invasive method, and presumably a lower cost compared to complex open surgeries. The key lesson, I think, was proof of principle. Effective clot removal, even if partial, could make a difference, and that a purely mechanical approach was feasible and seemed beneficial. It provided that initial spark. Minimally invasive techniques did have a role. And another notable purely mechanical trial came from Kim and colleagues in Korea. This was a randomized trial, 387 patients with small to moderate hemorrhages, average volume around 23 cubic centimeters. In their minimally invasive surgery arm, they used an Archimedes screw placed stereotactically through a burr hole. They reported significant improvements in clinical outcomes too, measured by the Barthel index scores of about 91 versus 62, p-value less than 0.01, and also the modified Rankin scale scores of 1.2 versus 3.0, again, p-value less than 0.01 at 6 months. So this further bolstered the case for purely mechanical evacuation. And then we have several meta-analyses that have corroborated these promising findings for mechanical techniques. Zhou and colleagues looked at 12 studies, almost 2,000 patients, comparing minimally invasive surgery to medical management. They reported robust reductions in both death, about a 46% relative risk reduction in death or dependence, about a 47% relative risk reduction with minimally invasive surgery. A separate meta-analysis by Yang and colleagues independently confirmed these findings, also showing a significant reduction in mortality or dependence with minimally invasive surgery. Interestingly, their analysis found that conventional craniotomy failed to show a significant clinical outcome benefit compared to medical management. So these studies collectively provided strong signals. Purely mechanical, minimally invasive techniques were offering a tangible benefit.
Okay, so these purely mechanical techniques showed a lot of promise. Less invasive clot removal was beneficial, but then there was also this period where thrombolytics were integrated, aiming for perhaps even more complete clot lysis. What about those trials involving thrombolytics? Did they bring similar benefits, or did they maybe introduce new challenges that complicated the picture?
Yes, that's an important distinction. While the purely mechanical routes were showing promise, there were parallel efforts to enhance clot removal using thrombolytic agents, basically, dissolving the clot chemically. Two small pilot randomized controlled trials in the U.S. specifically explored this thrombolytic irrigation idea. The first was the MISTY trial, minimally invasive surgery plus tissue plasminogen activator for intracerebral hemorrhage evacuation. They randomized 96 patients, 42 to medical management, 54 to minimally invasive surgery. Now, the MISTY procedure involves stereotactic placement of a sheath, manual aspiration of the hematoma, and then crucially, a flexible drainage catheter was placed into the remaining clot cavity. This catheter was then irrigated with tissue plasminogen activator for up to 4 days, trying to facilitate further clot breakdown. The investigators reported a significant reduction in perihematomal edema, suggesting maybe a biological benefit beyond just mechanical removal, perhaps reducing the inflammatory response to the clot. The second trial was CLEAR 5EH clot lysis, evaluating accelerated resolution of intraventricular hemorrhage.
This one focused on patients with small supratentorial hemorrhages, but large associated intraventricular hemorrhages requiring ventricular drainage. Patients were randomized to either saline infusion or intrathecal tissue plasminogen activator through their ventricular drain. They did observe that intrathecal tissue plasminogen activator increased the rate of intraventricular hemorrhage clearance, and subjects with faster, more complete clearance showed faster neurological improvement. However, there were significant safety concerns. About 23% of the subjects in the tissue plasminogen activator group, that's 6 out of 26 patients, experienced symptomatic rehemorrhage. 3 of those even required a craniotomy. That rehemorrhage rate was considerably higher than seen in MISTY-2 with parenchymal catheters, raising a red flag about thrombolytics in the ventricular system. Plus, it took an average of 10 days to get adequate clearance, which is a prolonged treatment course, extending intensive care unit time. So, building on these insights, we had the CLEAR 3 trial. This was a pivotal phase 3 study. It investigated intrathecal tissue plasminogen activator for intraventricular hemorrhage associated with small or no intraparenchymal hemorrhage, specifically below 30 cubic centimeters in patients needing an external ventricular drain. Patients got either placebo, which was just normal saline, or recombinant tissue plasminogen activator, 1 milligram every 8 hours for up to 12 doses infused to the drain.
The primary outcome was modified Rankin scale score less than or equal to 3 at 180 days. Overall, the trial showed that intraventricular tissue plasminogen activator had no significant effect on clinical outcomes for the entire cohort. However, looking deeper, there was a significant reduction in mortality at 180 days by about 11%, p-value less than 0.01. And safety parameters, like serious adverse events, were actually more favorable for the tissue plasminogen activator group, about 46% versus about 60% in the placebo group, p-value less than 0.01. In a specific subset, those with intraventricular hemorrhage volumes over 20 cubic centimeters, tissue plasminogen activator did significantly improve rates of good functional outcome, modified Rankin scale 0 to 3.
The data suggested that more efficient, more complete removal, specifically over 80% reduction, correlated with better outcomes. But despite these positives, it's important that most subjects, about 70%, did not achieve that substantial greater than 80% reduction with the Clear 3 technique, indicating limitations to that specific approach.
So thrombolytics brought some benefits like reduced mortality and maybe fewer overall serious adverse events in some contexts, but also introduced those significant concerns like symptomatic rehemorrhage and prolonged treatment times, especially in the ventricles. This clearly pushed the pendulum back towards purely mechanical approaches, focusing on physical removal. What about intraoperative computed tomography-guided endoscopic surgery, or ICES, as a purely mechanical alternative? What were its inherent limitations or areas for improvement that maybe newer devices could address?
Exactly. The ICS technique offered a compelling purely mechanical approach, aiming to sidestep some of those thrombolytic issues, particularly the rebleeding risk. The technique involves stereotactic placement of an endoscopic sheath right into the hematoma. Then the hemorrhage is evacuated using suction and irrigation. But crucially, an endoscope is used for direct visualization. This allows a precise assessment of residual hemorrhage and, critically, the ability to assess and potentially control active bleeding points, with cautery a significant advantage. Early experience with ICS was encouraging, though in smaller studies. A small single-center series of 6 patients showed impressive results. Operators got about 80% volume reduction and about 60% reduction in midline shift. Effective decompression. Another small trial randomized 10 patients to ICS or medical management. The ICS group, 6 patients, again achieved about 80% volume reduction. But in stark contrast, the medical management group showed an alarming enlargement of the hemorrhage, about 80% over 24 hours. However, that trial was halted due to slow enrollment. And the operators recognized that while promising, the technique needed more optimization, perhaps in a single-arm study first. The learning curve for endoscopic work in a clot cavity was also a challenge. More recently, a larger trial by Vespa and colleagues randomized 14 patients to ICs and 4 to medical management, also using the MISTI control arm for comparison. This trial showed about a 71% reduction immediately post-treatment. At 72 hours, the reduction in volume was significant, 21 cubic centimeters in the ICAs group, p-value less than 0.01 compared to the medical group. Although it was underpowered for clinical outcome, there was a noticeable trend towards good neurological outcome, modified Rankin scale less than or equal to 3. In the ICO's cohort, about 43% versus about 24% in medical management, though the p-value was 0.19, so not significant. Still, this study was instrumental. It demonstrated the feasibility and safety of ICs, providing a strong foundation for future purely mechanical approaches. The main limitations often revolved around the precision and speed of clot removal, especially for organized or adherent clot, and just maintaining effective visualization throughout. 3. The Artemis neuroevacuation device. A mechanical solution.
It really sounds like the purely mechanical endoscopic approaches were showing genuine promise. Crucially, without that rebleeding risk that was a concern with thrombolytics. And those earlier mechanical systems, while effective, still had areas for improvement, particularly around efficiently removing that tough, organized clot.
Which leads us directly, then, to the Artemis device.
Exactly. The Artemis neuroevacuation device represents a significant refinement in these mechanical approaches. It meticulously builds on those prior experiences and specifically aims to address some of those limitations. It's designed to efficiently and reliably evacuate intracerebral hemorrhage under direct visualization, aiming for maximal clot removal with minimal invasiveness, especially when dealing with that often dense, organized clot that can be really challenging for simple aspiration alone.
What exactly is the Artemis device, and how does it work differently to achieve this efficient evacuation of what can be quite tenacious clot?
So the Artemis device is a sophisticated surgical instrument. It evolved as a successor to the earlier Apollo system, incorporating lessons learned from that initial platform. It basically performs two main functions. First, controlled aspiration, like other systems. But second, it generates rotational energy. It connects to a standard penumbra aspiration pump, which provides the vacuum through tubing. The device itself has a rigid cannula, but inside that cannula is an internal wire. This wire rotates at high speed. And this rotational energy, combined with the vacuum aspiration, works synergistically to facilitate the removal of tissue and fluid. That rotational action is particularly crucial because it helps break up and prevent clogs within the cannula lumen. This ensures continuous and efficient removal, making it very effective for that organized tenacious clot that might otherwise resist simple suction. The Artemis cannula is also specifically designed to fit through the working channels of standard neuroendoscopes, like those from Lauda or Karl Storz, allowing the evacuation to be done under precise, direct visual control.
Okay, so it's a direct mechanical removal system aiming for precision and efficiency, even with challenging clot using that rotation. How does the procedure with the Artemis device typically work in a clinical setting for a neurologist considering this intervention for their patient?
Well, the procedural technique with Artemis is quite similar to the ICES procedure we just discussed, but with the enhanced clot removal capabilities of the device itself. It starts with stereotactic placement of a sheath into the hematoma. This is often guided by neuronavigation, helping the team select a trajectory that's feasible, hits the longest axis of the clot, and crucially limits damage to adjacent healthy brain. A burr hole, or a small, maybe 1 to 2 centimeter craniectomy, is made for access. Once the sheath is in place, the evacuation happens under direct endoscopic visualization through the sheath. The neuroendoscope goes in, and then the Artemis cannula is placed through the endoscope's working channel. Hemorrhage gets evacuated using the device's controlled aspiration and that rotational energy. Irrigation and aspiration are used simultaneously by the operator to maintain a clear view inside the sheath that's critical for safety and thorough evacuation. The technique often involves working from distal to proximal, evacuating the deeper clot first, and then serially retracting the sheath as the clot is removed. The position is continually monitored with neuronavigation. Ultrasound can also be used adjunctively to visualize the hematoma and guide removal. After adequate evacuation, the device and endoscope are removed, and the cranial access is closed simply. And a notable practical advantage, unlike some thrombolytic methods where drains are often left in for days, is that in many cases with the Apollo system and presumably with Artemis, no drainage catheters were needed afterwards. That can reduce infection risk and simplify postoperative care significantly.
Right, that lack of drainage catheters is certainly a practical plus in patient management. What's the recommended target for hemorrhage reduction with this device, to optimize patient outcomes based on what we're learning about volume?
Yes, the protocol specifically recommends achieving about a 65% reduction in hemorrhage volume during the procedure, and also aiming for a final hemorrhage volume of less than 15 cubic centimeters. These targets aren't arbitrary. They're directly based on those crucial insights from previous studies, including MISTY third, which we'll touch on more later. Those studies showed a strong correlation between hitting these thresholds and improved patient outcomes. Achieving these targets is considered really crucial.
And what's its current regulatory status? Is this device widely available for neurosurgeons in their clinical practice?
So the Apollo system, its direct predecessor, got FDA clearance back in March 2016 for controlled aspiration in the ventricular system, or cerebrum. And it received European conformity marking in May 2016, making it available in the US and Europe. The Artemis neuroevacuation device itself specifically received FDA clearance in August 2017, confirming its safety and effectiveness for its intended use, building on that Apollo foundation.
What about early experience data with this technology, particularly the Apollo system, which came first? Did it show a promising safety and efficacy profile that really set the stage for this dedicated mind study?
Yes, there is indeed some early experience data that showed positive indicators and really justified more rigorous investigation. An initial multi-center retrospective series looked at 29 intracerebral hemorrhage patients treated with the Apollo system. This series showed an average reduction in hemorrhage volume of about 54%. Furthermore, in about 48% of these subjects, the hemorrhage volume was reduced to less than 10 cubic centimeters, so getting close to that target range. In terms of safety, rebleeding was reported in 2 of the 29 subjects, which is about 6.9%. This early data suggested both the feasibility of this mechanical evacuation approach and a promising safety profile, particularly compared to some historical rehemorrhage rates. It definitely paved the way for the dedicated MIND study with the refined Artemis device. The MIND study, a pivotal randomized controlled trial.
Okay, so with that promising background and the refinement of the Artemis device, we're now at the culmination of this research journey. The MIND study itself. This isn't just another trial. It's designed to be pivotal, right? What's the primary aim, and what does it hope to achieve for our patients?
The primary aim of the MIND study is precisely that, to investigate the potential efficacy of minimally invasive surgery using the Artemis device to improve clinical outcomes at 180 days. This is for patients with small to moderate volume supratentorial intracerebral hemorrhage, and it's compared directly against best medical management alone. It is absolutely designed as a pivotal randomized study, specifically structured to look at clinical outcomes for patients presenting within 24 hours of symptom onset. The central hypothesis is straightforward. Treatment with minimally invasive surgery will significantly improve these functional outcomes at 180 days.
And how is the study designed to achieve this objective with the highest statistical rigor and generalizability, ensuring the results are truly meaningful for clinical practice worldwide?
It's designed as a prospective, multi-center randomized controlled study built for robust data collection and analysis. It compares two distinct treatment arms. Minimally invasive surgery with concurrent medical management, we call that the minimally invasive surgery group, against medical management alone, the medical management group. The study plans to enroll a substantial number, up to 500 subjects, across potentially 50 global sites. This large-scale international design is crucial for generating robust, generalizable data that reflects the diverse patient populations and clinical practices we see worldwide. That really increases the external validity of the findings.
Can you walk us through the target patient population? For neurologists thinking about referring a patient, who exactly is eligible for the MIND study? What are those crucial inclusion criteria?
Absolutely. The inclusion criteria are quite specific. They're designed to identify patients most likely to benefit and for whom this treatment is most appropriate. First, regarding age, patients must be between 18 and 80 years old, a broad adult population, but excluding extremes. For intracerebral hemorrhage volume, it must be supratentorial, and the volume needs to be between 20 and 80 cubic centimeters, measured using the standard A times B times C divided by 2 method. This targets hemorrhages large enough to cause issues, but hopefully not too massive. Hemostasis must be confirmed. That means no arterial spot sign on computed tomography angiography. And importantly, the hemorrhage increase must be less than 5 cubic centimeters on 2 scans taken at least 6 hours apart. We need relative stability.
Right, no active rapid expansion.
Exactly. Patients must also have a significant neurological deficit, shown by a National Institute of Health stroke scale score of 6 or greater. Their consciousness level is key too, needing a Glasgow Coma Scale score between 5 and 15. So, responsive enough to potentially recover. Regarding prior function, patients must have had a historical modified Rankin scale score of 0 or 1, good function beforehand.
So we can clearly attribute any improvement.
Precisely. The timing is critical. Symptom onset less than 24 hours before the initial scan, and the minimally invasive surgery itself must be initiated within 72 hours of the ictus, the bleed. That acute window is thought to maximize benefit. Finally, blood pressure control is essential. Systolic blood pressure must be below 180 millimolars G and controlled at that level for at least 6 hours before randomization. Crucial for minimizing rebleed risk. These criteria together aim to select a fairly homogeneous group where the intervention's effects can be clearly and safely assessed.
Okay, conversely, what are the key reasons a patient would be excluded from participating? These exclusion criteria are just as vital for clinical decision-making.
Yes, equally important. They're there to ensure patient safety and the integrity of the results. First, imaging exclusions. Patients with an expanding hemorrhage on that final screening scan are out. An arterial spot sign on computed tomography angiography that hasn't resolved is also an exclusion. Hemorrhagic lesions like vascular malformations, aneurysms, or tumors are excluded. Those aren't spontaneous intracerebral hemorrhage. Hemorrhagic conversion of an ischemic stroke is out too. Infratentorial hemorrhage is excluded, as is associated intraventricular hemorrhage that requires treatment for mass effect or shift due to a trapped ventricle. Now, an external ventricular drain just for intracranial pressure management is allowed, but not if its primary purpose is intraventricular hemorrhage-related mass effect.
That's an important distinction.
Yes. Other significant medical conditions exclude patients too. Active infection with fever over 38 Celsius, severe renal failure, creatinine above 2, or being on dialysis, and any comorbid disease expected to compromise survival or the ability to complete the full 365-day follow-up would also lead to exclusion. It's a comprehensive list to ensure a well-defined population and manage risk.
That is very thorough. How are patients assigned to their treatment groups, and is there any blinding involved to minimize bias, especially given it's a surgical intervention?
Right. Allocation concealment is key. Patients are randomly assigned using a central web-based interactive web response system. The randomization is done in a 2.1 ratio. So twice as many patients go to the minimally invasive surgery group compared to the medical management group. And this allocation is carefully balanced by key prognostic factors. The Hemphill score, categorized 0, 2, or 3, 4, and the hemorrhage location, low bar versus deep. This helps ensure the groups are comparable at baseline. Now, regarding blinding, it is an open-label study. Investigators, staff, and subjects know the treatment assignment. Surgery is hard to blind. However, to mitigate potential bias, there's a crucial control for the primary outcome. The modified Rankin scale assessment at 180 days is performed by an independent, blinded evaluator. And to help maintain this blind, subjects were actually provided with a hat during that assessment to obscure any potential surgical scars.
A hat. Interesting detail.
Yes, and if the blind is inadvertently broken for any reason, it's meticulously documented. The blinded evaluator also follows a strict, scripted interview to further control for bias during that critical assessment.
Okay, let's talk about the actual treatments. What does medical management, the foundational treatment, entail within the MIND study?
Medical management, which is the control arm and also provided to the minimally invasive surgery group alongside the procedure, rigorously follows the existing American Heart Association and European Stroke Organization guidelines. It's a comprehensive package. Admission to a monitored stroke unit or intensive care unit for at least 24 hours. Close monitoring and aggressive treatment of blood pressure. Meticulous glucose management avoiding highs and lows. Prompt treatment of any clinical seizures. Formal dysphagia screening before starting oral intake to prevent aspiration pneumonia. And correction of any reversible coagulopathies as determined by the managing physician, following standard protocols. The goal is to provide the highest standard of non-surgical care to everyone enrolled.
And the minimally invasive surgical procedure itself with the Artemis device, can you detail the steps involved from planning through to closure?
Sure. The minimally invasive surgery using Artemis is done under general anesthesia and must start within 72 hours of the ictus. It involves several key steps. 1. Preparation. This starts with uploading computed tomography or magnetic resonance imaging scans into neuronavigation software. This is used for meticulous planning, selecting a trajectory that accesses the longest axis of the hematoma while minimizing damage to healthy brain. 2. Access. A burr hole or a small, maybe 1 to 2 centimeter craniectomy is created. Then an endoscopic sheath, 19 French or smaller, is advanced into the hematoma using that neuronavigation guidance. 3. Evacuation. The neural endoscope goes into the sheath, providing direct visualization. The Artemis cannula is then placed through the endoscope's working channel. Hemorrhage is evacuated using the device's aspiration and that crucial rotational energy. Irrigation and aspiration keep the view clear. The technique often involves working distal to proximal, clearing the deeper clot first, then retracting the sheath. 4. Post-evacuation assessment. After the initial pass, an intraoperative computed tomography scan is done. This checks for adequate evacuation and any complications like rebleeding. Based on this scan, more evacuation can be done if needed, with that strong recommendation to get below 15 cubic centimeters residual volume and achieve about 65% overall reduction. 5. Closure. Once satisfied, the sheath is removed and the small access site is closed in the standard way.
And just to be absolutely clear, because this distinguishes it, no intrathecal tissue plasminogen activator or other thrombolytics are used during this specific procedure in the MIND study's minimally invasive surgery arm, correct? Purely mechanical.
That is absolutely correct, a critical distinction. The protocol specifically excludes any thrombolytic agents during the procedure for all subjects in the minimally invasive surgery group. So yes, MIND is rigorously investigating a purely mechanical evacuation strategy. This allows a clear assessment of the Artemis device's specific benefits and risks, without confounding factors or the re-hemorrhage risks linked to thrombolytics.
What about the follow-up schedule? How are patient outcomes assessed throughout the study? This is key for understanding the long-term impact.
Yes, the follow-up is comprehensive and rigorous, designed to capture both short-term recovery and long-term function. Early assessments include a post-procedural scan and neurofunctional exams within 24 hours for the surgery group and within 72 hours of randomization for the medical management group. There's also a day 7 or discharge assessment, whichever comes first. For post-discharge follow-up, subjects have visits scheduled at 30 days, 90 days, 180 days, and 365 days post-randomization. Now, the 90-day visit can be in clinic or by phone, and the modified Rankin scale at 30, 90, and 365 days can be done by phone using an approved questionnaire. However, the crucial 180-day modified Rankin Scale assessment, the primary endpoint time point, must be conducted in person by that blinded evaluator.
In person, right? That makes sense for the primary endpoint.
Exactly. And a variety of robust assessment tools are used. The National Institute of Health Stroke Scale, Glasgow Coma Scale for neurostatus. Functional outcomes use the modified Rankin Scale and the Barthel Index for activities of daily living. Health-related quality of life is measured with the EQ5D-5L. And additionally, the Stroke Impact Scale is used. That's a validated scale specific for stroke patients. It goes beyond physical disability to assess things like emotion, communication, cognition, social role function, giving a more holistic view of recovery. AMA 5, study endpoints and statistical rigor.
Okay, so with all these meticulous assessments and follow-up points, what are the key measures of success for the MIND study? What are its primary and secondary endpoints, and how is safety being measured?
The study has very clearly defined endpoints for both efficacy and safety. The primary objective, as we said, is investigating if minimally invasive surgery improves clinical outcomes at 180 days compared to best medical management. So, the primary efficacy endpoint is the Day 180 Global Disability, assessed using the Ordinal Modified Rankin Scale score. The hypothesis is that minimally invasive surgery will improve outcomes, meaning the odds ratio comparing the distribution of modified Rankin Scale scores between the two groups will be greater than 1, indicating a shift towards lower disability. For the analysis, modified Rankin Scale scores of 5, severe disability, and 6, death are combined, and deceased subjects are scored as 6. Then we have secondary efficacy endpoints. These give a more comprehensive picture. They include Day 180 and Day 365 average improvement in weighted modified Rankin Scale scores. Dichotomized outcomes, like the proportion with modified Rankin Scale 0 to 2 or 0 to 3, good functional outcome. Also, evaluations using the Stroke Impact Scale for activities of daily living and mobility, the EQ5D-5L for health outcome, and even things like length of hospital stay and length of intensive care unit stay. And for the primary safety endpoint, the key short-term measure is 30-day mortality. Any death occurring on or before day 30 post-randomization. A clear measure of early safety.
That's a comprehensive set of endpoints. How are they ensuring the statistical integrity of such a complex trial, especially with multiple interim looks in this adaptive design? That's crucial for the reliability of the results.
Right, the study employs a sophisticated adaptive design. This allows for flexibility and efficiency while rigorously maintaining statistical integrity. It permits interim analyses and decisions on early stopping for predicted success or futility. Interim analyses are planned strategically. The first one happens after 200 subjects have completed their 180-day follow-up or are confirmed deceased. Then more analyses after every additional 50 subjects reach that point. A key part of these analyses is imputing the 180-day modified Rankin Scale scores for subjects who don't have complete follow-up yet, making the analyses as robust as possible at each stage. The stopping rules are carefully defined. The trial might stop early for anticipated success if the predictive probability of success for currently enrolled patients exceeds a high threshold, 0.975. Conversely, it might start for futility if the predictive probability of success, even considering all potential patients up to the maximum 500, falls below 0.05. These rules prevent continuing a trial unlikely to succeed or one that's already shown clear benefit.
Power calculations suggest that if the true odds ratio is 1.7 or more, the trial has over 80% power to show superiority of minimally invasive surgery. In that scenario, the adaptive design means the trial stops early for success about 62% of the time, with an average sample size around 351 patients and a mean duration of about 44 months. It shows the efficiency gains of this approach. The primary endpoint analysis itself will use an ordinal logistic regression of those 180-day modified Rankin Scale scores.
Given the invasive nature, safety is obviously paramount. How is it being monitored throughout the MIND study to ensure patient well-being and provide transparent reporting?
Absolutely. Rigorous safety monitoring is built in, a multi-layered approach with independent oversight. 2 independent committees are crucial. A data safety monitoring board, made up of independent neurovascular specialists and a statistician, continuously monitors overall safety, reviews all safety data, and can recommend protocol changes or even early termination if needed. Separately, a clinical events committee, composed of independent medical doctors not involved in the study, adjudicates predefined adverse events and serious adverse events for causality, especially those related to the device and study endpoints, including all deaths. They are blinded to the overall primary results to maintain objectivity. All adverse event reporting is meticulous. Investigators record adverse events and adverse device effects thoroughly. All deaths are reported regardless of causality, with details on the primary cause. Deaths within 30 days or paraprocedural deaths within 7 days get particular scrutiny. There are several specific serious adverse events that are tracked very closely and reported quickly. These include symptomatic rehemorrhage or new hemorrhagic events, defined precisely by a significant neurological worsening, National Institute of Health stroke scale increase of 4+, or Glasgow Coma scale decrease of 2+, lasting 24 hours, needing emergency surgery or resulting in death. Similar rigorous definitions apply to symptomatic evolution of perihematomal edema, symptomatic ischemic stroke, and surgical complications like infection, abscess, meningitis, or anesthetic complications, all defined by that significant sustained neurological decline or need for intervention. And finally, any device deficiencies, malfunctions, or even near misses are meticulously documented and reported to the sponsor and regulatory authorities. This ensures ongoing product safety monitoring. It's a comprehensive safety net. 6. Intimate. Broader context. Insights from MISTI 3.3.
Okay, while the MIND study focuses on the Artemis device's purely mechanical approach, it's incredibly helpful to consider findings from other recent large-scale trials. MISTI Third, in particular, is a significant example that offers valuable context, especially regarding what effective clot removal might actually mean.
Yes, MISTI Third provides really important context for understanding this evolving landscape, especially given its scale and design. It was, as you know, a randomized, blinded endpoint, open-label, Phase 3 study, enrolled and treated nearly 500 patients across 78 hospitals globally. The MISTI arm subjects were treated with image-guided, minimally invasive catheter evacuation, but critically, this was followed by thrombolysis using tissue plasminogen activator. That difference, the inclusion of thrombolytics, is a key point of comparison with a purely mechanical MIND study. It highlights both shared goals and distinct methodologies.
So what were the key findings from MISTI Third, especially regarding efficacy and safety? What lessons did it offer about combining mechanical evacuation with chemical thrombolysis?
For the primary efficacy outcome, good functional outcome, modified Rankin scale 0 to 3, at 365 days, about 45% of the MISTI arm achieved this, compared to about 41% in the standard medical management arm. Now, while that shows a numerical difference, a trend, the statistical significance for this primary outcome wasn't met for the entire cohort. So it didn't hit its main goal for functional improvement across the board. Regarding safety outcomes, MISTI 3 provided some important nuances. Mortality at 7 days was significantly lower in the MISTI arm, about 1% versus about 4% in standard medical management, p-value less than 0.01. An important early signal. Mortality at 30 days showed a favorable trend for MISTI, about 9% versus about 15%, but this did not reach statistical significance with a p-value of 0.066. Complications-wise, bacterial brain infections within 30 days occurred in 2 patients in the MISTI arm, none in the standard medical management arm. A small risk, perhaps related to the indwelling catheter. Symptomatic brain bleeds within 72 hours of the last thrombolytic dose were comparable, about 2% in MISTI versus about 1% in standard medical management. Not significantly different. However, asymptomatic brain bleeds within that same window were significantly higher in the MISTI arm. So the thrombolytic increased non-symptomatic bleeding, a nuanced safety point. But overall, there were significantly fewer serious adverse events reported in the MISTI arm compared to standard medical management, 126 versus 142 events, and this was statistically significant, p-value less than 0.01. The authors concluded MISTI was safe regarding serious bleeding and infection, with procedural risks comparable despite the thrombolytic use.
That's interesting. Reduced overall serious adverse events in the MISTI arm, despite thrombolytics, yet the primary functional outcome wasn't met. Suggests a complex picture. Did MISTI Third also look specifically at the extent of clot removal? And if so, how did that precisely correlate with patient outcomes? This feels like a critical insight that could guide future interventions, including purely mechanical ones like MIND.
It absolutely did, and this is perhaps the most critical insight from MISTI Third, with huge implications for all minimally invasive approaches, including MIND. An exploratory analysis of the MISTI Third data showed a clear, compelling dose-response association between the extent of clot removal and better patient outcomes. This was really groundbreaking, providing tangible targets. Specifically, the analysis revealed that reducing the intracerebral hemorrhage volume to below 15 milliliters correlated significantly with a good functional outcome, modified Rankin scale 0 to 3. The odds ratio was 0.90, p-value below 0.01. And what's more, reducing the volume beyond that 15 milliliter threshold dramatically increased the chance of a good outcome by about 10% for every additional milliliter removed.
Wow, almost a linear relationship.
Almost. A very powerful signal demonstrating more removed is better, within safe limits, of course. Furthermore, achieving greater than a 70% volume reduction significantly increased the likelihood of that good outcome.
modified Rankin scale 0 to 3. The analysis showed each additional milliliter removed beyond that 70% reduction threshold translated to about a 6% improvement in the odds of a good outcome. It definitively shows a dose response. It's not just if you remove clot, but how much you remove that matters for function. The analysis also revealed that an end-of-treatment volume below 30 milliliters, or achieving greater than 53% volume reduction, was associated with a mortality benefit. This analysis was hugely significant. It was the first to establish these specific, quantifiable thresholds for volume reduction that directly correlated with both mortality and functional outcomes. These findings provide crucial guidance on what constitutes effective hematoma reduction, suggesting aggressive but safe removal is key. Outro.
This has been an incredibly detailed and I think really insightful look into the evolving landscape of intracerebral hemorrhage treatment, especially these minimally invasive approaches. We've covered the history, the challenges, the ingenuity leading to new techniques, and the rigorous design of the MIND-EYE study. What's the practical summary you want our listeners, our fellow neurologists, to take away from today's deep dive?
Okay, to reiterate the key points, the MIND study is a pivotal randomized controlled trial evaluating the Artemis Neuro Evacuation Device, a purely mechanical system, against best medical management for supratentorial intracerebral hemorrhage. Remember the key inclusion criteria: volume between 20 and 80 cubic centimeters, National Institute of Health Stroke Scale 6 or greater, intervention within 72 hours. The primary endpoint is modified Rankin scale at 180 days. Now, previous trials like MISTI-3 using thrombolytics showed a significant reduction in 7-day mortality and overall serious adverse events. But critically, MISTI-3 demonstrated that the extent of clot removal, especially getting below 15 cubic centimeters residual volume or achieving greater than 70% reduction, directly correlates with improved function and survival. The MIND study's purely mechanical approach seeks to build on these crucial volume reduction insights, but importantly, without the added complexities and potential risks of thrombolytics.
And here's where it gets really interesting for neurologists in daily practice. That data from MISTI-3, establishing those specific thresholds below 15 cubic centimeters, over 70% reduction, and linking them directly to recovery and survival, that's an absolutely critical piece of information. It strongly suggests that aggressive yet safely performed volume reduction is a key determinant for improving patient outcomes.
Which raises the crucial question that will shape our future practice. Will the MIND study, with its purely mechanical Artemis device, confirm and potentially even enhance these outcomes? Could it offer a new, perhaps even safer standard of care for our patients without needing those adjunctive thrombolytic agents and their associated risks? The answer could fundamentally alter how we approach intracerebral hemorrhage management.
Something for you definitely to ponder as these pivotal trials continue to shape our practice and offer new hope for our patients. Thank you for joining us for this weekly neurology deep dive. We really encourage you to review the full protocol and associated documents to truly grasp the depth and detail of this groundbreaking research.